We are in San Diego, California, and with a lot of people from the East who are thawing out here in lovely California at the ACC 15 meeting. You know, at every one of our meetings there are always some interesting papers analyzing NCDR data. So here at ACC 15, one of them is taking a look at temporal trends in care and outcome of patients with cardiogenic shock undergoing PCI. And to talk about this report from the NCDR, I'm with Dr. Siddharth Wayangankar, who is MD, MPH, and interventional fellow at Cleveland Clinic, cardiology fellow, but you were at the University of Oklahoma Health Science Center when this whole thing started. Yeah. So first, why did you want to do this analysis of NCDR data? Let's start there.
Yeah, number one, I mean, NCDR is known for, keeping a very robust database, and especially the Cath PCI registry has recently shown that their data has good fidelity. They published data on their data quality, which is pretty remarkable. Second of all, this is a topic which I've been thinking about a lot, because we think about cardiogenic shock patients who are the highest risk patients, and they are the ones which are vulnerable to the most mortality. And then there are studies where we have had several previous studies looking at cardiogenic shock patients, how they have been doing, and what we have found is the mortalities have been going down, and all the previous studies have attributed this to prompt revascularization. So my question was then, if that's the case, why don't we just study exclusively those patients who we think we are doing a good job by bringing them in within 24 hours, opening up their blockages in 24 hours, and see how these high-risk patients are doing and whether we are actually affecting their mortality or not, just to look at their trends, their outcomes, how we are managing them. And so I just wanted to know have a more contemporary analysis of this high-risk strata of the ACS population.
So the number of patients you looked at?
So we started off with, I think, 105,000, but we did not want to include transfer patients from other facilities, and we also did not want to include patients who had revascularization after 24 hours. So after removing those based on exclusion criteria, we had a total population of around 56,000 patients. And these are all cardiogenic shock patients because of acute myocardial infarction who underwent PCI in 24 hours. So essentially, we do see some distinct trends in clinical characteristics. So our study started from 2005 to 2013. And we see that patients in 2013 are less likely to have PAD, less likely to have chronic kidney disease, and less likely to be smokers, which is different from previous studies. We also note that the balloon pump utilization has gone down, and which is also significant. And the other significant issue we noticed was most of these patients presented with multi-vessel coronary artery disease, which essentially means that apart from the culprit vessel, they had other arteries which were more than 70% blocked. But this does not translate into multi-vessel PCI, which I know that in uncomplicated STEMIs, we just treat the culprit vessel. But the guidelines clearly state that in patients who are hemodynamically unstable or with cardiogenic shock, there is a room for complete revascularization. But we see that the operators are choosing to stay away from that and staying away from multi-vessel PCI. We also see some trends of anticoagulation, which kind of mirror that of ACS studies, whereby valvulotomy utilization has gone up and that of GPI and unfractionated heparin has gone down. But interestingly, when it comes to outcomes, we notice that the stroke rates have not changed, but we do notice that bleeding outcomes and in-hospital renal failures have significantly improved. This bleeding outcomes includes significant bleeding events as well as rates of blood transfusion. So there we are doing a good job. But unfortunately, the most important mortality continues to go up.
And significantly so, too. That was kind of surprising from 2005 to 2013. Also, post-procedural MI.
Yes, and post-procedural MI went up, but then when you're looking at a database and when you're looking at patients who come in with cardiogenic shock, and so the post-procedure MI can be a little bit skewed, that's why I think...
well, we're getting better at measuring. Which that also may have some effect on these numbers.
Absolutely. So I think we then made a robust model of adjustment. We adjusted these outcomes for all possible variables, and we still notice that these trends still hold true. we still have an increase in mortality despite adjustment of our data. And we still see a favorable decline in renal failure as well as bleeding outcomes.
And yet, despite aggressive therapeutic measures, mortality continues to climb. This is a tough crowd. What do you take away from this particular study?
Well, I think the important thing is there are several things that we need to consider. One is that maybe we have reached the nadir of what we could do because you have to understand these are inherently sick patients. And the other issue is, but there is still room for improvement, because if you look at discharge medications or pre-procedure or intra-procedural medication like aspirin, dual antiplatelet therapy, as you will see in the manuscript, that we are still not doing a good job with regards to discharge medication adherence and adherence to guideline-directed medical therapy. So there's always the room for improvement. Right. So maybe that can help translate to better outcomes in future. But this study does raise an important issue that there is something that we probably are not doing right, which we need to probably figure out. At the same time, it does kind of reflect the fact that it is possible that we probably are doing what is possible, but we are just getting more sicker patients now. Yeah, as more and more cath labs open up, as in America, cath labs are available within door-to-balloon time windows, and you would see that more and more people, more and more operators are doing such high-risk procedures. So, in order to at least give that benefit to the citizens of getting early and prompt revascularization, this study kind of sheds light into the fact that we are just dealing with much more sicker patients who are going to have high mortality, come what may. But at the same time, it points out to some of the deficiencies in the care that we can still improve on, and hope that will at least stem the increase in mortality that we see.
And you can go on acc.org and please check out a variety of papers from NCDR are being presented here at ACC 15. For CardioSource World News, I'm Executive Editor Rick McGuire.